To Brain Day 2019. I'm Rich Easton, the Chief Executive of the Neurological Foundation. Welcome you to our wonderful day of talks, events and community groups in association with the Centre for Brain Research at Auckland University. My pleasure today to introduce a couple of the speakers, but just before I do, I'm going to talk a little bit about the Neurological Foundation and what we do. A couple of things, housekeeping. If we need to exit, there's exits down the bottom and up at the top, and the toilets are out of the door and to the right. If there's an emergency, there will be warning lines, so tsunamis, avalanches, etc. Just please exit gracefully. And please remember to turn off your phones or put them on silent, because there's nothing more embarrassing than being the person that everybody looks at halfway through a speech. So the Neurological Foundation was formed about nearly 50 years ago, and we were set up to support two things. One, funding research into neurological conditions, of which there are over 1,000 different types of neurological conditions. And secondly, to provide education and awareness about those conditions back to the people in New Zealand. And today is all around helping us to send the messages about what is going on in the research world. There isn't any choice sometimes around neurological conditions. 1 in 5 people can be impacted them, and I'm pretty sure everybody will know somebody that is impacted in some way, shape or form by a condition, be it from migraine, Parkinson's, Alzheimer's or stroke, to many others as well. So funding research and the work that we do, helping the researchers here and in Otago, is really essential for finding ways to develop cures, or hopefully actually find ways of improving quality of life. The last 5 years, we've funded about $13 million of research across the country. The demand was about $45 million. We just didn't have enough money to fund all of the applications that we had along the way. So a lot of really important things going on. We also are really proud to be the supporters of the Neurological Foundation Human Brain Bank, which is actually based in this building. The team that Sir Richard Fall leads, managing brain tissues that people donate for researchers to be able to use. And secondly, we also fund the Chair of Clinical Neurology. We just re-entered into another 5-year relationship with Professor Alan Barber and the team which Cathy actually works within as well. So this month for us is all about our annual appeal, helping to raise money to support and continue the wonderful work that the researchers do along the way. And today it's my real great pleasure to introduce Professor Cathy Stinear. Cathy is the chair of our Scientific Advisory Committee and is also doing some amazing work around stroke. So she's going to talk to you, and then we'll have some time for questions, and there'll be runners, and we'll close at the end. So I'm just going to put up Cathy's slides, and please join me in welcoming Cathy.
Kia ora, Rich. Kia ora, Rich, and tēnā koutou katoa. It's great to see you all here this morning, and today we're going to be talking a little bit about how we are revolutionising stroke care in New Zealand. And before I start, I'd just like to acknowledge some of the organisations that have supported the work I'm going to tell you about: the Neurological Foundation of New Zealand, the Auckland District Health Board and the Health Research Council of New Zealand, and also, very importantly, my colleagues and collaborators, Professor Winston Byblow, Dr. Marie Claire, Professor Alan Barber and Dr. Suzanne Ackley. They're all absolutely instrumental in the research efforts that I'm going to tell you about. I'm just the really lucky one that gets to come out here and share their stories with you. So stroke, what is this? Well, stroke is actually the most common cause of adult disability worldwide. This is a massive problem. There are around 8,000 people who experience a stroke in New Zealand every year. And at any point in time, there are roughly 56,000 people living in our communities living with the consequences of stroke. And of course, those consequences aren't just confined to the people who've experienced the stroke, but to their family, their loved ones, and their communities as well. The rather alarming thing is that we expect around a 40% increase in these numbers over the next 10 years. So we've got a lot of work ahead of us. Now's the time to be significantly improving the way that we care for people who do experience stroke, and preferably just trying to reduce that increase, if that makes sense, as much as we can. So what exactly is stroke? Well, the simplest definition is that it's the acute onset of a neurological deficit that persists for at least 24 hours. And this results from a disturbance to the brain's blood supply. Now, most stroke occurs because there's a blockage in an artery supplying part of the brain. So that's what we call an ischemic stroke. A clot forms somewhere in the body, and it will move through the arteries, and those vessels get smaller and smaller and smaller, and it'll eventually find a vessel that it will not be able to pass through. So it blocks the flow, and so the tissue downstream is deprived of the oxygen and the nutrients that it needs. When that happens, it's been estimated that we lose cells in the brain at the rate of about 2 million per minute. So it's fast. These are very vulnerable cells, and they don't last long when their blood supply is severely compromised. The other 20% is called a hemorrhagic stroke, and this is where a blood vessel leaks or ruptures, and it's a similar effect because the blood that should be flowing through that vessel to the downstream tissues can't really get there because it's busy leaking out directly into the tissues, and it's not as useful that way. So, same thing happens. The downstream tissues are deprived of oxygen and nutrients, and those cells quickly begin to die. So time is brain. You just get 2 million cells a minute. So the catch cry is time is brain. Does anyone know the acronym for how to recognise the signs of stroke in you or someone you're with? And I'm not looking at you, Don. That fast? Fast. Excellent. What does the F stand for? Face. A is for arm, S is for speech, and T is for time. Excellent. If you just don't remember a single thing that I say today, I'm totally fine with that. Try to remember this. This is the most important thing that I will share with you today. Fast. If any one of these symptoms is apparent in you or someone you're with, call the ambulance. Don't wait for all three. You don't need all three. You only need one to call the ambulance. Tell them, I think this is a stroke, and let's get going, because time is brain. We'd far rather you turned up at the hospital, did some tests and worked out, oh, actually, no, that's not a stroke. Phew. Then if you turn up the hospital saying, oh, yeah, this started yesterday, and I called my GP, and he couldn't see me till the next day, but it's gotten a bit worse, so I thought I'd better come in. It's too late. Okay? Too late for what? Well, as I said, we've got these two big types of stroke, hemorrhagic and ischemic. Just to illustrate these a little bit better, because it'll help you understand the next part, this is what a hemorrhagic stroke commonly looks like. So some of these really small arteries deep inside the brain give way, and the blood leaks out into the tissue. An ischemic stroke is where we have a blood clot like this, gets stuck in a vessel, and so sometimes that affects these small arteries deep inside the brain. Other times, it affects these much larger arteries, and then it's quite large areas of brain that are affected. So lots of different types of stroke. I'm going to focus in this next part on the ischemic type, mainly because that's the most common type, and that's where a lot of really major improvements in stroke care have recently happened. How do we avoid having a stroke in the first place? Hearing from you. What are some good ways to reduce your risk of stroke? Diet. What about your diet? Fruit and vegetables. Exercise. Why exercise? What does it do? Gee, I'm pushing you, aren't I? Yeah. Diet and exercise. So you're right. You're absolutely right. These are all part of a really healthy lifestyle. But we need to think it through a little bit further about how it's going to affect our blood. Because ultimately, strokes are caused by problems with the blood and the blood supply. So we need to link it back to the blood. Anyone got any other thoughts? Blood pressure. Excellent. Hypertension, high blood pressure, is one of the leading risk factors for stroke. So making sure your blood pressure is well controlled and as low as you can kind of safely manage, that's a good idea. And there's simple things you can do, like just thinking about the amount of salt you add to your food. Right? That's a diet example. What else have you got for me? Cholesterol, excellent. So cholesterol leads to the formation of plaques, right? So sticky substances that stick to the inside walls of your arteries, those promote clot formation, a thrombus, which can then break off and head north into one's brain. So yes, being really careful about managing your cholesterol levels is really important. And that is helped by diet and exercise, and sometimes that's not enough, and medication is also needed to keep those levels at a sensible range. What else you got for me? Biggie, no one's mentioned. Atrial fibrillation and smoking. Yeah, those are the two I was expecting. So, well done. So smoking, absolutely, is a major risk factor for both types of stroke, actually, ischemic stroke and hemorrhagic stroke, because it changes the blood and it also damages the linings of the blood vessels. Marijuana, oh boy, yeah. We're going to have a big Q&A at the end of this, so I'm going to park that and we're going to come back to it. Atrial fibrillation, though, came up over here. Yep, so atrial fibrillation is where the heart is not kind of quite beating with a normal rhythm, so that it should be the top half, then the bottom half, so lub-dub, lub-dub, lub-dub. And instead, this top part up here, the atria, are sort of shivering instead of giving a nice, sensible, rhythmic beat. And what that does is it predisposes to the formation of little clots, which can then, again, go north and cause harm. Right, so there's not a lot you can do with your lifestyle choices about atrial fibrillation. That needs to be medically managed, right? But there are things you can do about those other things, like your blood pressure and smoking and cholesterol. And another one is diabetes, actually. So the things that you can be thinking about: make sure your blood pressure is in a sensible range. Do whatever you can about that. Don't smoke, ever. Don't start smoking. If you are a current smoker, get the support you need to try to quit. It might take several attempts, and that's okay. Lower your cholesterol if it's a bit high, right? And that, like I said, sometimes diet and exercise are enough, and sometimes they're not, and medication is also needed. Control diabetes. Uncontrolled or poorly controlled diabetes is another risk factor for stroke, because diabetes, again, damages the linings of blood vessels, and that creates problems. And just overall, get regular checkups. Doesn't hurt. And you might be thinking, wow, gosh, I'm young. I'm going to start thinking about this when I'm a bit older. Stroke happens at any age. And a third of the people we see with stroke are of working age. They're under 65. The people in our research are as young as 18. So it can happen to any one of us. So it doesn't hurt, does it? To think about your lifestyle choices, your blood pressure, and your cholesterol at any point in your life. Okay, so how do we treat it? Despite our best efforts with prevention, the stroke has still happened. Well, people who have an ischemic stroke, remember there's a clot stuck in there. I showed you a picture of that before. The idea is to get rid of that clot and restore normal blood flow back to the area of the brain being deprived. There's a medication that can be given intravenously called TPA, tissue plasminogen activator, and that is a clot-busting treatment. It's a very powerful drug, right? And so it can be administered, and it circulates around the body, and we hope enough of it finds the clot in the brain to dissolve it down and restore natural blood flow. The catch with it is that it does need to be administered within 4.5 hours of the stroke symptom onset, which brings us back to time as brain. Okay, think about that. The person you're with, or you, think you might be having a stroke. By the time you've called the ambulance gets to you, they get you to hospital. You can't just have this as you walk through the door, because it's a very powerful drug, and there are some people for whom it would be very dangerous to have this kind of treatment. So they have to check it all out. They have to check you out. They have to check your medical history. They need to do a lot of quite sophisticated brain imaging to know that this is a safe and appropriate thing for you to do. All of it takes time. Right, so that's why you have to get on with it and call the ambulance straight away to give yourself a chance of having this treatment if it's appropriate for you. What happens when we get this stroke? So this is 100 people, and the dark green people are people that are now able to function normally or fairly normally, who wouldn't have otherwise been able to do so if they hadn't had the drug. Right, so that's about 13% of people having this drug do a lot better than they would have otherwise. The light green people means that they're better. They're definitely better, but they're not sort of getting back to near normal. At this end, we have a couple of people who are actually made worse by this drug. and one who is actually severely disabled or even passes away. Like I say, this is a very powerful drug. So, yes, for some people this medication makes a massive difference to their life after stroke. But there's a big group, isn't there, for whom it really doesn't make a difference. They're going to land where they were going to land. So what can we do with them, for them, to help them have a better outcome? This is where clot retrieval comes in, and this is Professor Alan Barber, who, as Rich said, is the Neurological Foundation Chair of Clinical Neurology at the University of Auckland. He's a stroke specialist neurologist, and it's my great pleasure and privilege to work closely with Alan. So I'm showing you Alan because he really led a study that was conducted here in New Zealand into clot retrieval, and it was one of several large international multi-site trials that were all published at the beginning of 2015. That was a banner year for stroke here around the world. I'll show you why. Clot retrieval looks like this. Well, it doesn't look exactly like that. This is an angiogram, and it's showing you blood vessels in the brain. What you can't appreciate yet is that there should be a bunch of squiggles over here on the right, and there's not. And that's because there's a big clot sitting here, and it's blocking the flow. So what the interventional neuroradiologists and neurology team can do is put a catheter into the groin, squiggle up into the brain. Don't worry, you're asleep for this, because it just sounds awful. You don't know anything about it. Squiggle up, and you can actually see the wire here. Can you just make out that little thin silvery line? And you can see some of this is coming back, and here it is, blood flow restored. Wow, I know. So, I still feel amazed when I see this. And this is what they're doing routinely now. Apologies for the squeamish. They then pull it back out. This is what it looks like, right? So it's actually a little cage that they put in. It's called a stent retriever. So they put this thing and they open it like an umbrella, and that traps the clot, and they're able to pull it all the way back out. I like to tease Alan. I say this is just really advanced plumbing. You're just unblocking pipes. He's got a good sense of humour about that. But it is absolutely remarkable, and it has revolutionised the way that people are treated in that hyper-acute stage of stroke. So now, people who are appropriate for this treatment, they get to hospital hopefully in time, all that advanced imaging is done, they give EPA regardless to get things going, then they take them to the radiology suite and try and get that clot out. Now, small clots that have found their ways into really small vessels, not really amenable to that. This is the big clots sitting in the big vessels. And this isn't appropriate for all patients, and TPA is not appropriate for all patients. So there's still a large proportion, the vast majority of people with stroke actually don't receive these treatments. But for the ones who do, it can be absolutely life-changing. So far, to the end of 2018 at least, 491 people in New Zealand have been treated with this. You can see that the bulk has been here in Auckland. That's simply because Auckland started first, because the research was done here, so it was very easy to get going quite quickly on doing it in real clinical practice. And Alan has worked tirelessly to support teams in Christchurch and Wellington to build their capacity for delivering this important treatment for people in their region as well. So those numbers are going to go up across the board. And thankfully, we're a small country. And so that means that even though just at the moment we've only got these 3 main centres offering clot retrieval, you can see that most people are within 2 hours to 90 minutes of a hospital that can make this available to them. So there's a lot of helicopters flying around now with people looking for clot retrieval. So that sounded weird. So Auckland now offers this as a 24-hour, 7 days a week service. And we look after patients, as you can see, from Taranaki north. So far in New Zealand, 500 people have been treated this way, which means that statistically we know there are probably about 192 more people who are now less disabled as a result. 100 more people who are able to go home and be independent as opposed to having to stay in a care facility and be dependent. And about 80 more people who have avoided hospital level care. So for this 500 people, this investment in developing this treatment has been completely worthwhile, and it will continue to be completely worthwhile for communities throughout the country. So, clot retrieval, now available in New Zealand. We're very proud of that. Actually, there was a time there, I think in 2016 to 17, where we were doing more clot retrievals than London, right? Simply because we had the infrastructure already in place. But as I said, not all patients are eligible, and actually most do still experience some disability. It's not the miracle cure. You don't walk out clicking your heels back to normal, but you are markedly better off for having this treatment than if you didn't. So I hope I've shown you that stroke is caused by problems with the blood, and the acute treatment, which we've been talking about, is about the blood, unblocking pipes mainly. And prevention is about the blood. All of those things we talked about to lower your risk factors are about your blood. But recovery is about your brain, right? Recovery is about how does the brain adapt to and compensate for the damage that it has sustained. And this is where I come in. I'm the brain scientist. So I like to tease Alan and call him the plumber. I'm the electrician because I look after the brain. We're fine, we've got it covered. All right, so one of the real challenges in stroke rehabilitation is that people who look very similar at first can have very different recoveries and outcomes. So this is a graph showing you 40 people. It's research we published a long time ago now, but it's still instructive. You can see that as a group, people tend to get better over time. But if you look at the different lines, and they get to different places and so on. So this is just a functional measure called the ARAT, which is how well people can use their hand and arm. 57, many of us today would score that. And we measured them within 2 weeks, again at 6 weeks, 12 weeks, and 6 months after the stroke. So here's a pair of people who start in a similar place, roughly halfway on the scale. One person actually does pretty well, and by 6 months, their hand and arm function is almost at a full score. But the other one, not a lot of improvement after that time. Here's another pair of people who started out with more severe impairment. One had this spectacular recovery, the other was more gradual and more modest. I think the people that really trouble us clinically, really trouble us, are these people who within a couple of weeks after their stroke have really no meaningful movement of their hand and arm, and yet one of them can go on and actually make a pretty decent recovery, and the other one won't improve. And the problem for us clinically is that we look at them in the bed, not the same bed, 2 different beds, right? Just for clarity, if we just look at them, they look the same in terms of what they can and can't do. And that's hard to know what to do then as the therapist. And the person who's getting better, it would be easy to think, I'm doing a great job as a therapist. And the person who's not improving, that really knocks your confidence as the therapist. What am I doing wrong? Have I chosen the wrong treatments? Am I not doing enough? Why are these 2 people, and I'm giving them the same care, and one's doing great and the other one's not improving? Right? It's hard for therapists to manage that level of uncertainty. So we think that brain biomarkers could be pretty useful here, and we think that the function of key pathways between the brain and the hand and arm might hold some of the answers for us. So one of these biomarkers we obtain using something called transcranial magnetic stimulation, or TMS. This is a safe and painless and non-invasive way of testing those connections. It's pretty simple. You activate the movement part of the brain here on the side that's had the stroke. You put sensors on the arm that record very low levels of muscle activity. You see if we activate here, do we get a response here? Right? It's not neuroscience, actually it is. But it's very simple. It's very simple. Another way we can look at it is to look at those structure of those key pathways with MRI scans, and I've just highlighted for you here in blue the main cables that take commands, movement commands from the brain down to the spinal cord and then out to the body. A couple of ways we can do it. We've put these together into something called the PrEP2 algorithm, and I'm not going to spend a lot of time on this, we'll just whisk through it. It starts within 3 days of stroke, and it starts with the physiotherapist just evaluating strength, how strong a couple of key movements are. This movement, shoulder abduction, and this movement, finger extension. Those are each graded out of 5. This is a 2-minute job at the bedside. The scores are added together for a score out of 10. And we know that people who have a score of at least 5, 3 days after their stroke, and they're young, which is in stroke land means you're under 80, that's young, then these people are most likely to have an excellent outcome for their hand and arm within 12 weeks, they're going to do pretty well. If you are a little bit older, over 80 or more, you need a higher SAFE score, you need better movement initially to achieve that same outcome. You need a SAFE score of at least 8. If it's not, if it's 5, 6 or 7, you're more likely to have a good outcome for your hand and arm at 12 weeks. 2/3 of our patients come through this top half of the algorithm. So by knowing the age and this quick bedside test, the therapy teams can give a pretty accurate prediction at the beginning for what that person can expect for their hand and arm movement down the track. The other third of people are more affected by the stroke initially, and so their SAFE score is less than 5 at 72 hours. Now we need this TMS test to check the connections between brain and hand. The therapists do this themselves. It's no longer part of research, it's part of routine clinical care. And they're looking for this, which is a motor evoked potential, or MEP, to see whether or not that we can get a message through. If we can, then again that person is most likely to have a good, possibly excellent outcome. That's great. This is an exciting part of the job because these people often have no movement at the time of testing. And it's rewarding to be able to say to that person and their family, look, we know that things look pretty grim at the moment, but the connections actually still work. So you've got good potential, so let's go. Let's see how far we can get. Unfortunately, roughly half of the people who have this test don't have responses to the stimulation. We can't get a message through, and that signifies severe damage to those key pathways in the brain. Now it depends on their overall stroke severity. If their overall stroke severity, just using the standard clinical scale, isn't too bad, higher scores are worse, so a low score is good. So under 7, they're most likely to have a limited outcome for that hand and arm, but if the overall stroke is a bit worse than that, they're most likely to have a poor outcome. You can see that the accuracy for these two predictions is actually quite high, 85 and 90% accurate for these groups. The reason that these two groups can't do as well as these two groups is that they're not going to get fine control of that hand back, because that key connection that we're testing is responsible for fine control. And unfortunately, when it's broken, we don't have any therapies or treatments that can repair it. It's broken, right? So they may well get some movement back at the shoulder, maybe some movement at the elbow, and therapy is designed to help them make best possible use of that, right? So everyone gets therapy here, it's just that the goals need to change depending on the brain's physical potential for recovery. The focus for the rehabilitation, as I said, has to differ between these 4 groups, but everybody gets therapy. That's really crucial. And it's also important to understand that we're only talking about hands and arms. We're not talking about walking and balance and talking and swallowing and thinking and organising. All of those other things can be affected by stroke too, right? And this prediction tool is just for the hand and the arm. So we have to keep it in perspective. So we've tested this before it went into clinical practice to see what happens when you use this in the real world. We found that this information gave therapists more confidence. They had a better sense of where to go with their patient. It resolved some of that uncertainty I was telling you about before. This enabled therapists to give more focused therapy, which was tailored to the recovery potential of individual patients. And we think that contributed to people leaving hospital sooner because the therapy better met their needs. And that's a good thing. Well, certainly the bean counters like it, but patients and families like it too, right? People want to go home. You don't want to spend weeks in a hospital. So overall, we think that having this information probably increases rehabilitation efficiency, and we weren't able to detect any negative outcomes of that for the patient, their satisfaction, or how well they actually did. I'm just going to completely switch gears here for a second and talk about walking for a second, because at this point, everyone goes, that's great, what about walking? Walking is also very important. 60% of people with stroke need help to walk after their stroke. And independent walking is the most frequent goal. If you ask people after stroke, they will most commonly tell you, I want to be able to walk by myself again. It's a really important goal, understandably. So I'm just going to show you quickly some work being done by Dr. Marie-Claire Smith, who's a neurological physiotherapist and a postdoctoral fellow supported by the Neurological Foundation in our group. She's done some cool stuff. She's interested in making predictions about walking after stroke because your ability to walk determines both when you get to leave the hospital and where you go. Are you going home? Are you going into a care facility? What level of support will you need depends a lot on how well you're able to walk by yourself. Can you walk by yourself? So she's come up with this walking prediction tool called Twist, which we're currently testing in a validation study across the road in the hospital. It's much simpler than PrEP2, which is great. The first test is simply how well somebody controls their trunk, and this is, again, it's a relatively short bedside assessment that therapists can do quite readily. High scores are good, so if people are scoring more than 40, they will most likely be walking by themselves, no supervision needed, quite fine thanks, within 6 weeks. We've seen people with no movement at all in their weak leg a week after their stroke, and they are walking safely on their own within 6 weeks, provided they've got good control over their trunk. That's great. Again, it takes out so much uncertainty. However, if their trunk control is not very good, then we have a look at how strong their hip extension is, which is this movement. It's putting your leg back behind you, right? That's hip extension. Again, it's graded out of 5, and if people score at least a 3, they will be walking on their own within 12 weeks. If they don't, they will not be walking independently at 12 weeks. So we think this is important because we need to know not just whether someone will walk by themselves again after stroke, but when. When are they likely to get there? This really is helpful to families in particular, thinking about, well, how much support is Dad going to need at home? Is someone going to have to move in for a few weeks? How many weeks? Are we talking a couple? I could get a couple of weeks off work. But if we're talking 6 weeks, well, okay, we're going to need a different plan, right? So thinking about those options, thinking about, do we sell Mum's house? Or is she going to be able to live in her own home again after all of this? So the value of this information we think is quite high. The study we're now doing is looking every 2 weeks to try and give a more fine-grained prediction, which we think will be even more useful. So what have we achieved so far? Well, I hope I've shown you that certainly here at University of Auckland, through Professor Barber's work, we're leading treatment of acute stroke and leading the way for the rest of the country. And it's incredibly rewarding to see that now available to people throughout New Zealand. We're also developing these prediction tools for hand and arm recovery and walking recovery. And we're publishing this in some of the best journals around the world. And so we're garnering a great deal of international attention for our work in these areas. PrEP2 is now being looked at in several hospitals around the world, both in research and putting it into clinical practice. And so I had no idea, I could not anticipate how much of my working life was actually going to be diverted towards supporting hospitals in various parts of the world as they figure out how to do this in their environment. So it's great that here in New Zealand we've created something that the rest of the world puts a lot of value on and wants to use in their own practice. So how on earth have we done all this? Well, I think we've achieved these successes by doing our research in the hospital. We're very privileged. I consider it personally a great privilege to work with people who've experienced stroke just in the last day or two and their families. They're going through something really difficult and they're so willing to help us create new knowledge so that we can help all the people coming along behind them. It's very humbling and very rewarding. The great beauty of doing the research in the hospital, in that clinical setting, is that it reduces the time lag between the discovery and it actually being used in clinical practice. Because if you can do the research in that environment, you've actually solved most of the problems about then doing it for real, like not as part of research, but as part of routine care. So can anyone guess how long it typically takes for a new discovery to make it into widespread clinical practice? How long? You're going to have to speak a bit louder. 3 years? 7 years? 5 years? Any advances? Going to sit around there? Okay. Try 17. I know. It's shocking and sad. Think of all the people in that time who could be helped. It's shameful, actually. I'll get back to that. You'll be pleased to know that these acute stroke treatments I've described and the PrEP2 algorithm that is now practiced across the road have made it into practice in 18 months. That's more like it. That's what we're talking about. Why? I think there's lots of reasons why we've been able to shorten the gap. The key thing is we're doing the research in situ. We're doing it where it needs to be used. And we're very fortunate to collaborate with amazing clinical teams in the Auckland District Health Board who are really excited about improving the quality of their care, and they're welcoming this work into their practice. So we're very, very lucky here. What next? Well, we plan to continue building clot retrieval capacity throughout New Zealand at other hospitals so that it's readily accessible for everyone, including those people down in Fiordland. You'll notice no helicopter coverage down there. Don't do this on the root burn track. Okay, and we're implementing the Prep2 algorithm in practice in hospitals throughout New Zealand and around the world. And we're busy validating and implementing the TWIST algorithm for walking, both in practice here and around the world. We're also continuing to build our group. We're training and supporting the scientists and clinicians of tomorrow. And these are just some of the amazing people that we've worked with along the way, because ultimately, teamwork makes the dream work. Thanks. Remember this thing you need. And we have a few minutes now for your burning questions.
You didn't actually tell us what a stroke looks like. Is it just a big faint on the floor?
No.
Thank
you.
Yeah.
What a massive oversight on my part.
What happens in a stroke?
Let's back up. Okay. I'll have to fix my slides. So a stroke can look like many, many different things, and that's why it's hard to just give you an instant mental picture. But I think these three things are key features to look for. And as I said, you only need one to suspect that you or someone you're with is having a stroke. Right, so a droopy face down one side. If you ask them to smile, only one side goes up. Can't lift both arms. A leg might give way, right? Weakness in one leg. Or they can't speak a full sentence or find their words, right? Or their speech is really garbled. Any of those things mean call the ambulance. Loss of consciousness is actually uncommon with stroke. Most people don't lose consciousness. And the worst part is, it doesn't hurt. If it hurt, people would do something about it much more quickly. The good news, it's not really good news, the good news about heart attacks is that they're very uncomfortable, and people know something's really wrong here, and they ask for help quite quickly, right? But your brain doesn't sense pain that way, even though it's kind of the same event, isn't it? Heart attacks and stroke is very similar, a loss of blood supply to a vital organ, but one hurts and one doesn't.
So the eyes will be open?
Yeah, the eyes can certainly be open. They can be looking at you holding a conversation. I've seen video footage of a GoPro of a friend of my husband's who had a stroke while riding his motocross bike. Yep. And so it's from his helmet view, and you can see he comes off his bike at slow speed, he picks it back up on the dirt, kids are zooming past him, and he's trying to get his hand up onto the handlebar. And you can hear him frustrated and confused by this. Why can't I get my hand up to the clutch lever to get... So, yeah, anytime. Yeah. Over here? Oh, over here. I don't know where to look.
Hi, I was just wondering how stroke at a young age will then affect an ageing brain?
Great question. So stroke at a younger age is sort of interesting because the brain is still developing and changing. So a little bit depends on how young, right? So stroke can even happen before birth, and that can give rise to things like cerebral palsy, for example. And it can happen at any time in your life. Obviously, young people with stroke have not had a stroke because they've had a lifetime of cigarettes and pies. They haven't had time for those sort of lifestyle factors to kick in. So stroke in young people is usually due to other things that they were born with, like maybe a heart defect or a defect in the way some of their blood vessels formed in their brain. However, stroke in young people has very similar effects to stroke in older people. Sometimes stroke in younger people, depending on how big the stroke is and where it is, because the brain is still developing, it has some time to adapt a little bit better. So sometimes the outcomes can be better, but certainly not always. Yeah. I think it's a fascinating field of inquiry, and my colleagues overseas are doing beautiful work on this. Yeah.
Sorry. Thank you. The question was just to follow on the one you just, before this one. Can you have a stroke in your sleep?
Yes.
And?
Absolutely. Wake-up stroke,
What?
that's called. That's really tricky from a clinical perspective because I gave you some time windows for when the clot-busting treatment, the drug, is useful. So what happens if you hop into bed at, let's say, 10, let's say you're an early to bed, early to rise kind of person, you hop into bed at 10, you're asleep by 10:30, feeling fine, and you wake up the next morning about 5:30, and you go to get out of bed and one side of your body isn't working properly. When did you have the stroke? Was it 3 minutes ago, 3 hours ago, 6 hours ago? It's very hard to know, right? So clinically that's extremely challenging, and so we talk about time last seen well. When was this person confirmed as not having had a stroke yet? What time was that? And things are based on that. There's some important work being done to see if imaging can be used to estimate how long ago was that stroke probably, in the hopes of being able to help more people who with wake-up stroke. That issue is more critical for the drug than it is for the clot retrieval. The clot retrieval can be done a bit later, if it needs to be done a bit later, which is why in a regional hospital they might get the drug going and then pop them in the ambulance, bring them to Auckland, and then they'll take the clot out. So they don't have to happen sort of instantly together. But obviously the longer you leave it, the more damage has been done. Yeah.
I have two questions. First one is, what is the difference between a stroke and a TIA?
Yep.
And number two, is there a time limit for clot retrieval, absolute time retrieval?
Yeah. Okay, excellent questions. The differences between a TIA, so TIA stands for transient ischemic attack. Sometimes people call them a mini stroke, you might have heard that. So these are situations where there has been usually a little blockage. It's more common that it's been a little blockage than a little bleed. A little blockage somewhere that creates some neurological symptoms, and then they resolve because maybe that clot breaks down on its own, or it's so small that you're able to compensate for it, right? And TIAs aren't candidates for the sorts of acute treatments I've been telling you about, the drug or the clot retrieval, because it's all too small and it's happening very quickly. Most people with TIAs, by definition, feel that they get back to normal. The issue with TIAs is that it's telling you and your doctors that you're at a much greater risk of a stroke, right? So they need to be taken very seriously, and people need to be really carefully evaluated to make sure everything is being done to lower their risk of a major stroke. So we have a good system in this region for caring for people with TIAs to minimise the chance of them having that big stroke. But it's always disappointing when somebody comes in and says, oh yeah, I've had these couple of funny turns and I went and saw my doctor, we thought it was probably okay, I had 2 of those last week, and now they're in with a massive stroke. And maybe if that had been picked up and dealt with a little bit more aggressively at the time, perhaps there might have been a chance of preventing that big stroke. So they have to be taken very seriously. Just because it goes away again doesn't mean you're off the hook, is the thing to take out of that. Your second question was hard time limits for clot retrieval. They have been done up to 24 hours after stroke symptom onset, but I'm always reluctant to tell you that because I want you to be in a hurry to get to the hospital. So just delete that, all right? But in honesty, yes, they can be done quite, but the outcomes are never as good, and it's unusual to be doing them that late. Yeah. Yeah, there was a question way up the back. Runner, was there anyone closer over this side? This lady here.
Thank you. Is there a difference in the symptoms between hemorrhagic and ischemic strokes?
Not really. There's very little difference because the signs and symptoms depend on the part of the brain affected, and that part of the brain could be equally affected by a clot or a bleed. So the actual presentation is often, there's no way of knowing, which is why, but the treatment's totally different, which is why getting to hospital quickly so they've got time to do the imaging so they can see which type is so important. Clearly, if you've got a bleed happening in your brain, you don't want to have a drug that's going to make your blood thinner. No, that will take you in exactly the wrong direction, right? So this is really, again, get there as fast as you can so they've got time to get the imaging done and figure out exactly what's happening. Way up the back here.
Hi. With someone I know, elderly, that's had a stroke at the end of last year, he was told immediately to cut down on salt intake, and he has been in rest home care since. But now he's got low sodium, and I know someone with low sodium that's in their 90s, and it's so hard to handle when they've also got a catheter and things like that. So how do you deal with that when you're meant to drink, to hydrate?
Thank you. I mean, I can't comment obviously on that particular case, but it's an excellent reminder that people are allowed to have more than one thing wrong with them, of course. And the older we get, we kind of seem to accumulate this baggage of stuff that's not quite right, don't we? So by the time, yes, we're at those more advanced ages, chances are our stroke risk factors are not the only things that we have to worry about. There are probably several other things going on. And it can be a very fine line, can't it, between how do you manage to get the perfect level of sodium in your blood? Difficult. But certainly monitoring and having good conversations with one's doctor is the sensible approach. Accepting that there is often no perfect solution in those very complex situations. Yeah. Down here. Sorry, I'm just kind of waving my arms around. It really depends on the runners. I don't have a lot of control over this, I'm sorry. You guys just need to go fast. Up the back. Hello.
Yeah. Hello. Thank you very much for all the useful information. I also had a family member who experienced a stroke. So he was lucky enough to have not so many physical consequences, but I know there are lots of people who also experience psychological consequences. Sorry. Yeah. So I would like to know, how does that happen? How does it affect someone psychologically? Is it more the drugs or the structure of the brain that changes? Or?
Thank you. That is such a good question, and I always hope somebody brings this up.
Thank you.
So you're quite right. People experience a lot of things, a lot of changes in their thinking and their mood after stroke, and that changes over time as well. So it's estimated that between 30 and 60% of people with stroke will experience depression at some point in the first 5 years after their stroke. And there's a couple of ways to think about that. One is that, well, your feeling organ, your brain, has been injured, and that's probably knocked it off balance in terms of its chemistry. So perhaps there's quite a physiological reason that makes you more likely to experience low mood and depression. I also think it's a pretty natural response to something like this. I would be really concerned about somebody who had a major life event like this and just went, yeah, cool, I'm good with that. Yeah, see, that's not normal, right? So it's normal to go through a grieving process. It's normal to feel really angry and sad about what's happened and what's been lost. On top of that, people can experience difficulties with their thinking and their ability to express themselves. So now you've got these difficult emotions that you're grappling with, that you're struggling to sort through and struggling to express. So all of those things together make it really hard for that person and their family, because it should also be acknowledged that the loved ones of people with stroke go through their own adjustment period. And that includes anger, stress, sadness, grief. All of those other things happen for them too. And I think the really tricky bit is that people work through these emotions. Ideally, people eventually get to the point where they can go, okay, this is it. This is our new life after stroke, and it's not what it was before, but it's still a life worth living, and we're going to make the most of it. That's called acceptance. And everyone involved, the person with stroke and all the people caring for them and all the people who love them, we hope, arrive there at some point. But they're all going to get there at a different speed. They're all going to get there at a different time. And that mismatch can create a lot of tension in relationships, right? Some people get there way before the other people in their immediate circle. Some people don't get there at all. And so that creates a lot of difficulty sometimes for people living with stroke and their family, because they're in different places with grieving and acceptance for what's happened. So yeah, it's a real issue that we're aware of, and certainly the people, particularly in the community, like the Stroke Foundation and community rehab teams, are very sensitive to these issues and offer, I think, excellent support for people with stroke and their families. Does that mostly address your question? Yeah, thanks.
I just wanted to say that my husband had a stroke a couple of years ago. None of those symptoms were visible. He was sitting up in the chair, but he was not responsive to me. And the thing that really chimed was tea.
Yay for tea!
And I thought something serious is happening. I don't know what it is, but I better get hold of somebody who does.
Yeah.
So that was the first point.
I'm going to respond to that really quickly. You make a good point. These are simply the 3 most common signs of stroke. There are other signs of stroke which are much less common, but this is a general public education message. So we have to go with what are you most likely to see. And I would argue that his non-responsiveness to you comes in under S, speech. He wasn't responding.
No.
So no speech is just as bad as garbled speech or speech that doesn't make sense.
It's not much good looking at that and thinking doesn't apply. It's thinking this is not right.
This is not right. Trust your instincts and call the ambulance.
And
there was a part 2. Yeah.
Part 2. He had the clot retrieval.
Oh, okay. How'd that go?
So impressive. That team scrambled in the middle of the night.
Oh, yeah.
And just came in, and you would not believe it.
I would.
Well.
Oh, yeah.
Not being exposed to such things, it was very, very impressive.
It is impressive, and it's moving.
Yes,
it's moving for the clinical teams involved. They might sort of have that moment when their phone rings at 2:15 in the morning and they've already been back in once at 11 p.m. They've just gotten back to sleep in. We're back in again. This is 24/7. These are senior consultants all around the city. And they do it anyway. And they get in there and they absolutely give their best. And when they're tired, Alan has some pretty crazy stories about how, the lack of sleep sometimes. And when they're tired, it's still just so rewarding for them to see what a difference it can make. Not for everyone. We have to be a little bit cautious here. We're not talking magic. But for some people, it is phenomenal. And I still get goosebumps sometimes thinking about those people.
I heard about that procedure at a brain day.
Oh, there you go. And now you've heard about it, all of you, at Brain Day.
What was going on?
I think we've got time for just 1, maybe 2 more very quickly. We are going to get back to marijuana, but we're just going to answer this question here. Sorry. Marijuana, gosh, you're good. You're keeping me on my toes this morning.
When pathways to limbs are destroyed in adults,
yes,
can new ones ever be forged or developed?
No. That's the simple, short and sad answer. We don't have any treatments that can replace lost brain tissue. People are working on this. That's the good news. And I sincerely hope that within my professional lifetime, we will have something to offer that. But at this point in time, there is no treatment that we can offer that can replace those lost pathways. Once they're gone, they're gone. And so our job in therapy is to help brains and the people that own them learn to live as well as they possibly can with what they have left. And there's a lot that we can do to help that process, a huge amount. Therapy is so worthwhile, right? So you can't be nihilistic about this, but we do have to accept. It's a little bit like losing toes to frostbite. There's no amount of positive thinking is going to grow them back. It's so sad, but it's the truth. And we have to grapple with that truth and do the very best we can and continue hoping and supporting the researchers who are working to solve that problem. Marijuana, cannabis, last thing. Professor Barber actually led the world's first study showing that people who are cannabis users are at a heightened risk of stroke. A little bit to disentangle because, of course, they also have some other quite unhealthy lifestyle choices. They smoke often. So a little bit hard to completely be clear on, but certainly he was the first in the world to show that cannabis use increases your risk of stroke. This is important as we're coming up to a referendum on the legalisation of recreational cannabis. I'm going to leave you hanging on what I think about that. But please, before you vote, educate yourselves. Think really carefully and get good quality, credible information before you make a decision on how to vote in that referendum. That's all I have for you. Thank you. You've been great.